Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much, Dr. Abdullah, Dr. Rosano, for including me in this program. I have 10 minutes, and I was thinking about what can I cover regarding evolving imaging approaches for diagnosis of cardiovascular diseases. So I thought I'll pick a few recent developments in imaging, and I will try to be comprehensive in terms of covering multiple modalities. And I picked things that are either available or ready to be implemented in our practice. So I'll start with the evolving approaches or emerging approaches on the diagnosis of coronary atherosclerosis. Photon counting CT is one of the breakthroughs in imaging, and it is currently available with one vendor. But the premise of this is to improve spatial resolution, and the technological advance here is the availability of photon counting detectors. To simplify it, the old detectors for a long time, we used to convert photons to light, light to energy, and this is the energy that the computer translates into pixels. Now with the availability of semiconductors, we are capable of counting photons right away. So you remove one step, makes it more efficient, makes it more sensitive, and the image that you see at the left bottom side of the screen is the type of image that you get. What about the applications in cardiovascular disease? This is a study obtained with a photon counting CT. Because of the sensitivity and the higher spatial resolution, you have a higher ability to differentiate calcium, stents, and the lumen. So you have improved ability to have better diagnostic accuracy. You can remove the contrast as the image in the middle, because you are so good at differentiating between contrast and vessel wall and so on. And as you can see, this improves your ability to read, improves the ability to incorporate this data set into planning. And this was recently shown in a paper from a single center in New York. This is a cardiac CT. On the left was obtained with a conventional CT that we all have. On the right is the one obtained with photon counting CT, and you see your ability to differentiate the vessel lumen from the calcium, your ability to determine stenosis severity was significantly improved. It's a pretty large study on 7,800 patients. Almost half of them received the conventional energy integrated detector, and the other half received photon counting, and what they found that there's significant improvement in the positive predictive value. And that was really the Achilles heel of cardiac CT. And of those of you who do cardiac CT, we tend to overcall stenosis severity on CT. So you will look at the CT, you will see, oh, this is a 70%, you send them to invasive angiography, and it turns out to be 30 or 40. And that has to do with the inherent limitations of the technique that is available today, volume averaging and so on. So with photon counting, because of the spatial resolution being substantially higher, the positive predictive value has improved. And you actually send the right patients to the cath lab. So if they have mild to moderate disease, you keep them out of the cath lab. When you send them to the cath lab, the right patients go there and receive revascularization. So in summary, this is an available modality. Several places in the United States and in Europe have this technology, significantly higher resolution, improves positive predictive value, and you triage patients properly in and out of the cath lab. Radiation dose is slightly higher, and the cost is high for now. And once you have this technology, you can improve the applications of cardiac CT beyond just diagnosing coronary atherosclerosis. And this is an evolving concept of using CT for planning PCI. You can work with the data set, you can simulate if you were to put a stent there, what would happen, and so on and so forth. This is an evolving concept. It's not widely available, but something to keep an eye on for the coming few years. We'll move on to a different disease, infective endocarditis, a very common disease in this part of the world, and admittedly a challenging one. This is a patient that I believe many of you have seen, patient with a prior aortic graft and a bioprosthesis, comes in with fever, stroke, elevated biomarkers, inflammatory markers, and you're suspecting endocarditis. Your go-to test is going to be echocardiography, and these are the images that you will see. Hard to tell what's going on around the valve. You send them for TEE. You see some abnormal flow, some phlegmon involving the valve. Is it endocarditis? Is it not? It will be hard to convince the surgeon just based on these things to take them back to the OR for a redo surgery. So what has evolved is the role of cardiac CT and the role of PET FDG. This is a cardiac CT, a gated cardiac CT, that is not really important to diagnose endocarditis, but to diagnose the complications of endocarditis, root abscess, extension, fistula, and so on. And the other tool that is now widely available is the role of PET FDG, where you can simply send them to PET using FDG that tracks mononuclear cells. You see that there is a corresponding, in this area here, there is a corresponding uptake FDG that tells you there is a suspicious area on CT, a high number of mononuclear cells on PET that is consistent with prostatic valve endocarditis. And this is now considered one of the major due criteria according to the modified document that was recently released late last year. And this document, I strongly encourage all of you to refer to, shows you where do advanced imaging modalities fit in your workup. I'm not saying that when you go back to clinic tomorrow and you suspect prostatic valve endocarditis, the first test should be CT or PET. No, echo should be the first test, but keep an eye or keep these modalities in mind. So this is an excellent modality that is available, works excellent for prostatic valve endocarditis, and it has the ability to detect systemic disease. However, there is low specificity, especially in the first 6 months after surgery, and there is an issue with or learning curve for those who are not used to working with PET. Moving along, I will not finish this session without mentioning cardiac amyloidosis. The non-invasive diagnosis for cardiac amyloidosis relies on the use of SPECT, but this is not a perfect test. There are limitations, especially in certain genetic mutations, where the patient has ATTR cardiomyopathy, but their SPECT or the PYP scan is negative. There is a pan-amyloid PET tracer that was FDA approved recently. It binds to any amyloid fibrils, and it has 100% sensitivity for diagnosis of amyloidosis. And this tracer is currently undergoing phase 3 testing. So this is going to be a game changer, but I worry about the availability of PET scans and access to physician and patient access to PET scan. So with that, I would close, and I'm right at 10 minutes. Thank you so much.